Hello, good evening.
Evening.
Oh, how you guys doing? I hope
Good
you
evening.
guys enjoy the holidays, have a good time with family. It was a little long break, a little longer than expected, so hopefully you took advantage of that and have some good time. Okay, so let's continue. This is gonna be the last chapter of this module. So let's see if we're gonna finish earlier than usual. So let's see how it's gonna go. Once again, these chapters mostly are very repetitive. So you're gonna encounter lots of information that we have covered because we need to integrate that with other aspects of the medical records, whether it's electronic, whether it's paper-based. So we are in the part of the electronic, but still remember, because the information that is contained within the medical records is considered legal, protected, then we have to play with this information back and forth, whether it's paper or electronic. So this chapter is going to mention something about some additional health information systems. We mentioned some of them. We're going to encounter them again, and we're going to encounter some little things here and there that we have not mentioned already. So just to make a little recap, we cover what it is medical records in general and the different types of medical records. Remember, we have um, a problem-oriented medical records and source-oriented medical records. Remember, you have to know that for your exam. That's important. So again, we're not going to go over every single detail, but just taking some points in consideration. You need to know about HIPAA regulations, whether it is privacy, confidentiality, or security. Remember, privacy has to do with the information of the patient should not be left unattended. For instance, if you're using paper-based medical records, should not be on top of the counters by itself. You should not just leave them anywhere. Has to be in the hands of the doctor or on the shelves. That's basically what it is. If we are not using them, they need to be in a secure place. That comes with the patient's information. That, remember, this is privacy. Also, if it is, we have a systematized medical records in the computer, we should not keep the electronic information that someone can see it. So the screen should have a screensaver or log off every single time that we not using the system. Remember that you will be assigned a login and a passcode, and you should not be sharing that information with no one. That will be violation of privacy. It's not security. It's not confidentiality. It is privacy because it was privately given to you. So you have to use it. Nobody else can use it. So remember, once again, these are questions for your exam. If it is regarding the patient, privacy means you should not expose the patient. You should not start, doing a procedure where other patients can see the patient. If we have curtains, we should close the curtains. If we don't have curtains, we should close the door. So that's basically what it is. If the patient needs to undress, disrobe, well, you should direct the patient to disrobe only the necessary garment needs to be removed, because otherwise will be violation of the patient's privacy and dignity. So we don't do that. Every single time that we are dealing with the patient, we have to tell the patient not only identify the patient that we have the correct one, But also we're telling them, asking them for a consent. Remember, some of the procedures, we don't need a written consent. We need just a consent. Patient said yes or no. The patient just agree by the patient's behavior of actions. The patient just not agreeing with you. The patient just take a seat or laying down on a bed, just agreeing with the procedure. So those things are considered privacy. Remember, that's very important. We talk about how to correct errors, whether it's paper, whether it's electronic. Remember, if it is paper, 100% question on the test. You need to draw a line through the error, then write down the correction, whether on top of the error or below the error. Then we're gonna date it. We're gonna place the date and the time that we change it. Then we're gonna put our initials, not signature. Medical assistants and nurses do not sign anything. They put the initials. The medical doctor signs. Medical records needs to be completed at least within 24 hours. What is completed? That all the information is within the medical records and the doctor needs to sign that. So that's basically what it is, because we need that information and it needs to be completed. So other professionals within the facility can use that information if it has been completed, like for billing purposes, for referral purposes, for insurance purposes. So we need to keep that in mind every single time that we deal, regardless whether it's electronic or paper. We have to keep privacy. Now remember, confidentiality, on the other hand, is releasing the patient's information to someone without the patient's prior authorization. And as we discussed this already, patient needs to sign a form that is called release of information form. And it needs to give details to who and for which reason these information from the medical records are going to be released. So that's basically what it is. Remember that organizations, associates, organization that works with the care of the patient, they do not need an authorization of release of information. That was signed the day that the patient registered. They have the authorization because these are people who works with us for the care of the patient, whether some associates that are helped other health departments or specialties, or financial, which is insurance purposes. Remember that the insurance, the health insurance of the patient, will not pay us if we do not submit a claim stating diagnosis, procedures, services. Services is not the same as diagnosis, is not the same as procedures, not the same. Services means the day of the visit. So the patient went over there, okay, it's a new patient, how much time the patient spent with the doctor, that's services. We cannot use these terms as a, regular, ordinary, routine things that we talk on our daily activities. Oh, I'm gonna pay for services. It means a lot, but in medicine, it is totally different. It focuses only on the visit. I go to see my doctor for a follow-up. That is service. I need my blood results. That is a service. So they're gonna give me the results. Now it is a procedure if they have to draw my blood. That's a different issue. But whenever a patient goes to see a doctor, all these is included. It has a service, is the time of the visit. It has procedures if they order blood or any body fluids collection. or if they order CAT scans, MRI, any of these images, electronic images, that is procedures. Labs, those are procedures. Surgical procedures. So we need to distinguish between these because you're going to get confused when they give you these terms on the exam. The patient charge, the medical doctor charge or wants to be reimbursed for services. It's a new patient. So that means is how long the time the doctor spent with the patient. Usually it's 45 minutes because it's a new patient. A follow-up, 15 minutes. A procedure, 45 minutes to 1 hour. Simple procedure, surgical procedure is a different issue. It can last hours, but we need to know what is the difference. Remember, we talk about the SAOP, the SOAP note. S stands for subjective. This is what the patient tells us. These are the symptoms. I have a headache, I have a back pain, I'm not being able to go to the bathroom, I'm peeing too much, I have a rash, I can't walk, I have nausea, I have diarrhea. Anything that the patient complains about, that is subjective. Then we're going to have objective. All the investigations that the medical providers are doing. The exams that the medical does, the tests that they order to confirm exactly what it is. So that will be objective, because objective is something that I can see, something that I can prove. Symptoms, you might see then it's a rash. Yeah, but you don't know what it is. What causes it? What condition is it? So rash is just a general statement. Pain is a general statement. So in general, what the patient always complains about, which are called symptoms, that's considered subjective. Assessment is just the diagnosis. That's it. Should not get confused. What is assessment? Diagnosis. Patient was diagnosed with the flu, with COVID, with this type of cancer, with diabetes, with high blood pressure, with high levels of cholesterol, with anemia, with arthritis. Anything that the patient is being diagnosed, that is called assessment. Plan. Plan is what we are going to do. What treatments we are going to give to the patient that we have already diagnosed with this condition. Now, the treatment can be medications. The treatment can be surgical procedure. Oh, we need to fix this. That's the only thing that is going to fix the problem. So not necessarily the treatment is giving the patient medications. Now, it can be a surgical procedure, physical therapy. So that's how it works. When we talk about medications, treatments, I said medications because I don't like to say drugs, but this term is very commonly used. What drugs the patient needs. Okay, Tylenol is considered what drug? Things like that. They're not going to ask you that, but this is how, medicine utilizes the word drugs. So I don't like to talk much about drugs because sometimes people mix them up with illegal drugs, which is not what we're talking about. That was the name that they gave because it's a combination of different chemicals. So that's a drug. So if I give you an infusion, an intravenous, intramuscular, subcutaneous, topical cream, those are medications. It can be in any form. Next module is going to be pharmacology. So we are going to talk about all the types of medications and the routes that we're going to use those medications. And why is it that we have so many medications in different shapes and forms and ways of administering them? So we're going to discuss that. But we are talking about treatment. So that's basically what it is. So you should not forget about, remember the SOAP, because definitely they're going to ask what the S stands for, what O stands for, but not necessarily like that. They're going to tell you, okay, the doctor ordered blood. What part of the SOAP is that? Oh, wait a minute. That is objective because those are the tests that the medical doctor is ordering because we don't know already what the patient has. That's not a treatment. The patient just complaining about pain and, in the head or headache or body ache, something like that, or diarrhea. Well, we're going to run some tests because I'm still don't know. I'm halfway. So you got to use that ladder. You're going to go in a descending. You go from the S, look what the patient says, then the objectives, so everything that the doctor do to make sure that they come out with the diagnosis. Then we have a diagnosis, and then we have the treatment. So that's how you're gonna get the question. So it's not like, okay, S stands for subject, that would be easy, right? But it's not like that. The patient complains about headache. What part of the SROAP note is that? Oh, subjective. The medical doctor did some evaluations to the patient and ordered some blood tests, some imaging reports. Which part of the SOAP? Oh, that is the objective. The patient was diagnosed with diabetes. What part of the SOAP is this? This is A for assessment. Okay, the patient went home with certain medications. What part of the SOAP is? Oh, that's the plan. That's the treatment. So that's how it works. So remember, during the test, you're going to be asked about simple things. Things that not for you, it's not simple, but for us in the medical is what we use very often. Things that are used very often, that you encounter very often, that is what you will be asked. Not things that doesn't happen often. It's whatever put you at risk, put the patients at risk, the company at risk, you will be asked about that. That's what we talk about HIPAA. That's what we talk about OSHA. Because that put us at risk, whether the patient or staff members or the organization altogether. Remember, when we said the organization means we get sued. When we said the patients or the staff, well, we can get injured, or staff members can get sued as well. So that's putting you at risk. So for that reason, we're going to continue with these additional health information systems. There are some terms that you will never see because it's part of the system. Remember that electronic medical records was added back in 2008. And since then have been, evolving, have lots of changes. Because it's making things a lot easier. Think about your cellular phones. The way that the first cellular phone was useful, but it didn't have many features. Same goes with electronic medical records. When it started, it was very simple, very basic. We had to do almost all the work. It was like giving us a blank slate, and you had to fill in the blanks. So that's basically what it is. Now we have menus. Now we have almost every single information there. We just have to check which one applies to the patient. So again, a lot easier now to deal with electronic medical records than before. A lot easier to use the computers now, the cell phones, than back in the days when they first came out. And it's going to continue improving, evolving, because it's going to make our lives a lot easier. So that's the purpose of this class. So when you encounter yourself in a workplace, particularly when you're gonna do your internship, just ask how it works, what system they have. You might not some student probably, but if you know someone might walk you through, not showing you everything, not giving you a login and a passcode, because usually students do not get access to this. It's for employees. But you can see someone working on it, and you can ask them to show how it works. And you're going to see that it's very, very, very simple. If you know how to maneuver these Teams application, you're definitely going to be able to do anything else. If you know how to, surf in the net with your cellular phones, you're definitely going to be able to do it. Remember, there are different types of software applications out there. Probably the one that Dr. A has is not going to be the same one as Dr. B or C or D or so on, and so forth. So get familiar with them. This is the purpose of these classes is for you to pass that test. And that's what it has information that actually you're not going to encounter most of them in your workplace. Sometimes, when I took classes, I was like, okay, so this is going to be very complicated, my job, because I have to do all of these. Actually, no, they just want you to know regulations, just want you to know how the system works and why it was built that way, so it can protect the information of the patient and, can find someone liable, someone who has access to these medical records, so we know who did it, who entered the information, when the information was entered, and so on and so forth. So that's basically what it is. So health information system. Remember, these acronyms, you're not going to be asked. Like, what is HIS? They're not going to ask you that. This is health information systems. In medicine and any other industries, we use lots of acronyms. Remember, people mix this up with an abbreviation. And within the exams, sometimes they use the same terminology. They don't say an acronym, sometimes they say it, but grammatically speaking, HIS is not an abbreviation, it's an acronym. Once again, what is an acronym? An acronym is when we use the first letter of each word. See? H, health. I, information, I, and S is the system, S. Now, if we were talking about abbreviation, means it's a shortened part of a word. See, administrative. So for administrative, I don't need to type the whole thing. I just put admin. Admin, that's it. That's called administrative or administration. That's it. Information, info. See, it's just one word, and we use a very short part of it. That is an abbreviation. Abbreviated means shorten something that is long. But acronym is when we use the first letter of each word, because there are many words right there. HIPAA, that's an acronym. OSHA, it's an acronym. CDC, it's an acronym. WHO, WHO, the World Health Organization, that is an acronym. So that's basically what it is. So just understand that when they ask you something, they use these terms interchangeably, but it's wrongly used. So abbreviations and acronyms do not mean the same. It's just that sometimes they just use it that way. So don't get confused. Just try to figure it out. So that's basically what it is. So the health information systems include both clinical and administrative systems. Now, once again, we're not going to discuss all the little details because that's not the purpose of the class, right? But what you do need to understand is that these new applications, these software applications that we use in the system, they are used for gathering all the clinical data, arranging this clinical data, and then storing this clinical data electronically. In the same fashion, we're going to work with the administrative part. What is the administrative part? Anything that has to do with the information of the patient. The demographics, that includes patient's name, address, date of birth, social security, marital status, gender, weight, height, all those things are administrative. Insurance, who's going to pay for the services? That is administrative. Appointments, that's administrative. Making referrals, it is administrative. Billing and coding, anything that has to do with, reimbursing the medical doctor for services, that's administrative. Calling patients to reschedule. Well, we could talk already about patients' appointments. All that is administrative. Anything that we deal outside of the clinical part, purchasing supplies, that's administrative. Paying the bills, paying you the salary, that is administrative. So that's basically what it is. And these software applications that we use in the medical field, they have to have both. They have to be compatible for both clinical and administrative. Otherwise, it's not going to work. Because if we render services, we offer services, then we need to be compensated for it. Then that's the administrative part. So that's basically what it is. That's why whenever you have a question in your exam, remember the medical office is divided into parts. The administrative part, the front, and the clinical part, the back. So that's how it works. Now, probably you notice when you join this program that it says the clinical medical assistant, the administrative medical assistant. It has two components. So that's basically what it is. You want to be working in the front only? Well, you don't want to do anything on the clinical. You don't want to learn how to draw blood, how to do EKGs, how to do vital signs, how to assist the doctor doing procedures. Then no worries. If you don't like that, then you just do the administrative part. So that's how it works. That's why these medical offices, when I'm talking about medical services, medical office, we're talking about hospitals, anywhere where patients are seen, where patients are treated, and when we charge for those services. So the software application is going to cover both. So that's basically what it is. And that's what it's called the health information system, because we're going to have a system that is utilized for both clinical and administrative. Okay, any questions about this definition? Okay, EHR. Remember, we talked at the beginning of these electronic medical records because we have electronic medical records, electronic health records. It's going to be a question for you. You need to know the difference between those two. We discussed this already, but I'm going to repeat it one more time. Electronic health records, this is an acronym. Remember, EHR. This is what we use all the time. We use acronyms because it's a lot easier. So EMR. This is electronic medical records. Remember, electronic medical records only works, it is computerized digital system, but it only is, the purpose is to serve that particular organization, that particular building. The information cannot be shared outside the building. So let's say that I live in my building. And if I use EMR, I'm going to be sharing this with the entire building, meaning the people who has to do with that particular organization. But I cannot send it out to my friend's house to someone else's building. It stays right there. It's a localized system just for that. Now, electronic health records, on the other hand, remember, this is the one that uses this interface, interoperability systems, which we can send, we can share this information from our office to the outside. If I have electronic medical records and I'm working in another building, even though if it is the same hospital, I'm working in one of the satellites of this hospital, but I'm not in this particular base, then I'm not going to be able to open information from one base to the other, from one hospital to the other. Whereas electronic health records allow me to share the information not only with anyone in the surrounding area, with another state, with another country. Even I need internet services. EMR needs internet services, but it is a local internet just for that particular office. So whenever you see a question, it says, okay, your electronic, they don't say electronic record, they said, you need to send a file to another department outside of your hospital. What system are you using? Electronic health records, because it's going outside. So that's how you are going to answer the questions. And that's what I'm giving you, like a very, very basic definition of what is considered electronic medical records and electronic health records. Electronic medical records were the first one that came to the market. So we were using these medical records within our facility. We didn't sharing our information. We didn't have no interface. Everything was within. No interoperability. We didn't care about what would other systems somebody else were using because we're not sharing the information with them. But here, with the electronic health records, we are. So we have to have all these gadgets, all these applications that have been added to the system so we can share the information and we can actually, send information from one building to the next, to another town, to another state, outside of the state. See, I was on vacation with my mom. I'm just giving you an example. I'm telling you that I'm all the time on vacation. No, I was on vacation with my mom and we went to Florida because we have family members over there. So we stay over there. My mom had some medications needs to be, have a refill. We didn't go there for a couple of days. We were there for over a month. So my mom ran out of medications. So I said, no worries, mom. You have, we're going to go to any of these clinics and we are going to get your medication refill. And that's how it was. We went to one of those offices, medical doctor.
Professor, you put yourself on mute. We can't hear you.
Hello?
Okay, we can hear you now.
Oh,
Yeah, we can hear
please,
you now.
please, if you feel like something is not, because I have, the volume was not high, so probably that's the reason. Let me know, send me a text. Maybe you send me a text and I didn't check it out. So send me on the chat something that says, Professor Royer, we cannot hear you. Oh, probably you sent it. Okay, because I've been talking and talking, explaining you, giving you answers for the questions, not just reading. So I want you to get the whole information, because other than that, it's like we're not doing anything here. So I was talking about the difference between EHR and EMR. Remember, these are very, very important definitions. So EMR, remember, this was the first version of the digital medical records. After paper, we moved to the EMR. So why did they use electronic medical records, and what is it that they're using electronic health records now? No idea, but I believe that electronic doesn't change, right? Now, medical, because we're talking about your information, the patient's medical. Health, because it's the same as medical, they just want to make a difference between those two. That's probably what it is. But the big difference right here is with electronic medical records, you cannot share information outside that hospital, that medical office. Electronic health records, on the other hand, you can share the information to the outside. So you probably didn't hear me then when I said, that I went on vacation with my mom to Florida, just to give you an example how important it is to have electronic health records versus electronic medical records. So my mom needed a medication refill because we actually stayed in Florida for over 3 months. Electronic medical records. Now see the difference between this and this. So we just went to a nearby hospital and we talked to the doctor, says, listen, my mom needs a medication refill. So it says, oh, sure, where are you guys from? It says, we're from New York. Says, okay, so they asked me about my mom's information and they asked us permission to contact the hospital, and they contact the hospital here in New York. And they, right there from their computer, they got the refill for my mom. So we didn't have to return to New York to get the refills. We got it right there in Florida. I went to somewhere in Europe also myself. I ate something and it didn't go that well. I went to one of the hospitals there and they treat me and they charge my insurance from here because they have electronic health records. I'm telling you this so you know the big difference between electronic medical records and electronic health records. If my doctor or the place where I'm taking my medical services didn't have electronic health records, I wouldn't be able to use my insurance over there and to have some information about my health directly from that particular hospital overseas and here. If they will have electronic medical records, I wouldn't be able to do anything because they wouldn't be able to verify that I actually have an insurance that actually is active, that is going to pay for their services, even though if I'm overseas. Or my mom's prescription, they wouldn't be able to do the refill because remember, electronic medical records only is localized, is within that particular hospital building. They do not go away from this building. That's it. You're going to share the information with anyone, every single department in your building, in your medical office, but you cannot share the patient's information or any other information directly through the electronic system. That's what I'm talking about. You have to make a phone call, you have to fax something, and that's going to take time. And if you are overseas, are you making an international call? That's not going to be, it's better to pay for the services than to make a phone call because it's going to be a lot more expensive. And people is not going to be giving you information just because you call. So remember, this is the way things are working right now. It's very important. Prior to this, I was talking about the SOAP. Remember this SOAP note. You need to know that for the exam. You need to know not what S stands for, what O stands for, what A stands for, what P stands for. No, they're going to give you samples. The patient is complaining about headache. What part of the SA note, the SOAP note is? S, the subject, the subjective. The doctor runs some lab tests, some blood tests. What part of the SOAP note is it? Oh, that is the objective. I need to run some tests to figure out what you have. The patient was diagnosed with diabetes, high blood pressure, high cholesterol, anemia, whatever conditions the patient may have. That is the assessment. That is it. Oh, the patient was sent home with these medications. What type of the SOAP note it is? So then you immediately have to tell them, oh, that's the treatment. After the diagnosis, remember, goes treatment. For treatment, you can have a surgical procedure. Now, remember, I was talking also about services. If you couldn't hear me before, services. Services is not like in general what we use in our commonly daily activities. Oh, I need service for this. And service is a very general statement. In medicine, services are not everything. Services are only the time that the patient takes to be examined by the doctor. That is what we call service. It's not servicing the computer. It's not giving service to this or that. No, this is not what is called service. So when we ask for reimbursement for services, is for the time that the doctor spent with the patient. That is service. If we will run tests, we send you for CAT scans, MRI, all these imaging reports, then that is called procedures. That's called procedures. If they do a surgical procedure, that's called surgical procedure. They do surgery. If they do rehab, oh, wait a minute, that is plan. That is treatment. So if I give you medications for you to take home after I have your diagnosis, that will be treatment, that will be the plan. But the plan can be a surgical procedure. We need to remove the appendix because you have appendicitis. That's the treatment. Yes, I'm gonna give you medications as well, but a procedure, surgical procedure, it is considered a treatment to relieve the problem that you have. So that's what you need to understand. I was making a recap at the beginning, but I don't know if everybody heard me or not. But again, remember, you need to know about HIPAA. You need to know about confidentiality, privacy, security. Remember, security rule only applies for electronic information, not for the paper-based medical records. Because when we talk about security, we are talking about your login and passcode that you've been given by the administrator in your company, so you can have access to the electronic medical records. And you should not share that information, that login and passcode with anyone else. That's part of the security. So that's basically what we have: a firewall in our systems. We have antivirus that is considered security, because we need to protect that information that it is within the system. Without passcoding, login and a passcode, someone else cannot enter my computer. If a hacker tried to send me something through the system, well, I'm gonna have an antivirus. These computers, these electronic devices, all of them come free with security gadgets or applications. So to prevent damage to your computer, losing your information through other sources that might want to harm your system. So that's what I was explaining at the beginning. So it's very important that we keep all these, because that is the purpose of the class, to give you most of the insights, even though if you're not going to be using them later on, but you need it for you to pass your exam. Because if I don't give you all these lectures, how are you going to respond to the questions for the exam? You're not going to be able to. Remember, your exam is one thing. What you actually going to be applying to your job, it's a little different issue. You're going to be using some of that information. But here it's more like technical versus practical. So that's basically what it is. So we were talking about here, oh, what is all this information that I have? Hospital. Oh, so the first part, because I don't know if you heard me or not. HIS stands for Health Information System. Remember, it's written on top. That's the title. So we have HIS, Health Information System. Now, this is used in every single industry, but in medical, we use health, and other companies, information systems, and whatever else they do in over there. but we are concerned with the medical part. So in medicine, we use two parts of the health information system, the clinical part and the administrative part. Remember, medical offices or hospitals, whatever you want to call, wherever we see patients, we render services, we charge for those services. They have two components, the front and the back. The front is the administrative, and what's going on within the front? Oh, that's where we register the patients. That's administrative. That's when we check the insurance coverage for the patient. That is administrative, financial. That's when we collect all the information from our patients. Patient's name, patient's last name, social security number, phone number, address, all these demographic information. That's administrative. That is where we make appointments. That is administrative. That's when you do billing and coding. That's administrative. Then we move to the back, which is the clinical part. You're gonna draw blood, you're gonna do EKGs, you're gonna assist the patient, the doctor with some procedures, if they do any. We're gonna do vital signs, that's the clinical part. You're gonna do phlebotomy, you're gonna collect biofluids. That is part of the clinical. So remember, any medical setting is divided in two, front and back. Front is called administrative, the back is called the clinical part. So that's basically what it is. So we have to have a health information system that covers both the clinical and the administrative part. We need to know to whom are we rendering services? Who is going to pay us for those services? So that's basically what it is. So it's very important for us to understand these basic terms, because it's not, to make it complicated or anything. I just want you to understand in very, very simple terms. And that's what it needed. Every single practice utilizes this type of health information systems nowadays. Whether it was paper-based or not, it's just that electronic makes things a lot easier versus paper. Because back in the days, everything has to be written down. Now, everything is electronic, a lot easier to manipulate. Interface. Now, remember, interface only happens with electronic health records, not with electronic medical records, because now we are going to share this information. So we're not having only interface, but later on, we're going to talk about interoperability. We mentioned this prior. So all these systems applications, they use that, but electronic health records has interface. So we can collect information from different sources. Electronically, we can share that information. Remember, if I'm seeing my patient right here in my office, but then I refer my patient to a specialist, that specialist do not have to start collecting information from scratch. That medical doctor doesn't have to receive paper-based copies and start reading all that and trying to figure out what it is. No, I'm just gonna send information from my medical records, from my patient medical records, from my office to the particular person. And I can select what information I wanna send to them. Remember, this information sent to someone else has to be only send the necessary information. It's not everything. We never send everything. So that's how it works. We can retrieve easily information because it's right there in the system. Everything that I need. I'm going to do interface with the pharmacy. I'm going to do interface with the laboratory. When I'm talking about laboratory, I'm not talking about just blood and body fluids. No, I'm talking about with the imaging centers, because I'm going to get these X-ray, these CAT scans, the sonograms right there from the X-ray from the laboratory right there to my computer. But it has to have an interface. And not only I'm going to receive, then I'm going to be able to see it, evaluate, and then store them in my computer. So that's the beauty of electronic health records. Not just interface, it's more than that. But this is just one of the pieces of the puzzle of health records, electronic health records. So that's how it works. So remember, electronic health records is what we actually using now. But they're going to ask you those questions about the difference between electronic medical records and electronic health records, which is what I covered already. Now, there is a question here that is asking why multiple information. One company is not the one that builds everything. See, one company that is medical related have something that is for that particular specialty. Remember, we do not have just medical. We have different specialties, different approaches, different uses, different vendors, different manufacturer companies that create these software applications. So that's basically what it is. So each one of them specializes in something. Says, oh, I'm very good with the financial part. So whenever we buy these systems, now we don't have to buy them separately anymore. Back in the days, we need to. We got some part of the software from this vendor, another part from this other vendor, and so on and so forth. Now, the vendors, they kind of merge and create one product. So I don't have to look for this particular vendor for this particular health information system. Now, it is a complete package. I have to pay for it, yeah, but I have to pay anyways if I buy this separately. So that's basically what it is. So now we have different vendors, different manufacturer companies that create this software application, because now we need, now we know, I'm talking about these manufacturer companies, software manufacturer companies, they know already what are the needs of the patients. Because remember, electronic medical records was new. This is not something that has been going on for a long time. This has been going on for many years, yeah, but not too many. So that's basically what this is, was like 2006, 2008. And by 2014, 15, most of the medical offices should have, you know, incorporated all these systems. But now are better than ever, because remember, back in the days, you had to have a huge room when you have all this equipment, very expensive equipment. But what are you going to do with the equipment if you don't have the people, the personnel that is going to be working on that equipment? Well, you have to have a IT personnel. You have to have a programmer, computer programmer. Can you imagine how much they charge? And all these technicians, and give maintenance to the equipment. Very expensive. When we're talking about how expensive it was, at that time was over $1 million. Do you think that a medical doctor office has $1 million to just implement electronic medical records? I don't think so. It's too much money. So the government just kick in helping these organizations, particularly the hospitals. Nowadays, it's a lot easier. Having electronic health records is like buying internet service. It's like having Netflix. That's simple. I don't have to have no equipment in my practice. I just have an application, just like Teams, just like Facebook, but with other, little things. But it's the same way. I can use the service. Somebody else have all this equipment and they sell me the service. Now it's a lot easier, cheaper. So most of the people, most of the medical practices, now they have adopted this system. But back in the days was really hard because it was very expensive. That's what the government gave the medical practices, like a period of time of 10 years to adapt themselves to the new technology, because you had to spend a lot of money. So that's basically what it is. That was back in the days. So once again, if you are a large company like hospital, you will be able to afford it because you have a lot of money. But what about a doctor's office? They couldn't do it. And again, these systems has to incorporate everything that is needed to get this system rolling with all the features that are needed for it. Remember, you have to have this interface with the labs. You have to have labs that are going to be sent from the laboratory directly to the system, and the medical provider or whoever else medical personnel can see what was sent there without us the hassle of receiving paper information of that big film that they used to send for x-rays or CAT scans or MRIs. Now you have to put it like under light and try to figure it out what it is. That was very hard at that time. Now things there is right there. It is incorporated. So that's basically what we're talking about. So here we go again with the patient registration system. Back in the days, we had to do it on paper. You gave a form and the patient has to fill out that form. And remember, when the patients have issues completing that form, whether it's in paper, whether it's electronic, what is it that we as medical assistants are gonna do? We're gonna ask them if they need some assistance completing that form. Why? Because sometimes they have problems trying to understand the form, and we can help them out to complete it faster and accurate. This is very stressful when you are asked to fill out forms that you're not familiar with. And we need most of the information from you, because as much information as we get, better for the clinician to treat this patient. So remember, with the registration, we're gonna have the patient's demographics. I already told you, whenever they ask you about demographic information, is everything that has to do with the patient. Everything that is related to the patient. This is the administrative part. So again, not only the patient's information, but insurance information. It says right here, the warrantor and insurance information, because we're gonna use this for financial purposes, for billing purposes. We gotta get compensated for the services, or you're gonna pay us cash, or you're gonna pay us through an insurance company. Now it's a warrantor because you might not have an insurance yourself. You might be a dependent. So we need information of the person who is the primary insured. So we need the name of the person. You can't just use an insurance as if were yours. That doesn't work. I don't have insurance, but I'm a dependent. Okay, so who's the primary insured? That's the warrantor. So you got to give that information. If you are in a hospital and you've been admitted for any condition, we need to have a diagnosis what you were admitted. Remember, this is for billing purposes. And when we discharge you, the document that we're going to give you as a discharge has to be documented what was done during the period that you were there and for how long you were there, because this is the length of services, LOS. Remember, patients in an ambulatory setting, we don't pay for that. What do you mean length of services? You're charging for your patients for waiting in the waiting area 3 hours. No, that's not what it counts. What it counts is from the moment that I call you and start seeing you, evaluating you. And when you're admitted, then it is the responsibility of that institution, that hospital, to take care of you. So you're going to be receiving some care over there from the moment that you are admitted. So from that moment, we start charging for those services. Remember, when a patient comes into the outpatient's clinic, when the doctor calls you in and start talking to you about what brought you to the office that particular day, that's when the time start counting. And if I spend 15 minutes, that's the services. If you are admitted for 24 hours, 20 hours, 30 hours, 3 days, a week, a month, 3 months, 6 months, well, that's the length of services. There we're gonna have, remember, when you have your patient registration, we're gonna have everything about your decisions, your advance directives. Are you an organ donor? There we're gonna have a document for that. Do you have a DNR, do not resuscitate order? That's gonna be part of the administrator. So we need all those documents at the time of registration. Why? Because if something happens from the moment that we took you, on board for services, we need to know what to do just in case something happens to you, because we don't know what's going to happen. We have a consent form right there, because when you sign the registration form, you are consenting to us to release your information to all our associates, the people who is taking care of you, as well as the insurance, because they are the one that's going to pay for your services. So we have a lot of forms right there. Remember, lots of information. We're going to have forms for family history, social history. So all this information that is collected at the time of registration, this is the time when you join the practice. That's basically what it is. We are going to assign you a medical record number now. So from now on, you are part of our office, because this is the first step when you join the office. You have to register yourself. But registration does not mean, okay, I'm here because I want to see the doctor. Oh, sure, not a problem. Do you have insurance? Yeah. What insurance you have? Oh, let me check. That's it. You don't know. We have to get you through. You have to get all the information from the patient, because that's going to be the beginning of your electronic, your medical records. Just put it that way. Think about the time that you registered for the school. You went to the school, or you call on the phone, and then, fill out some papers. You brought some papers, like high school diploma probably, some picture ID, and you have to fill out papers if you apply for financial aid. We need to know about you. We need to know who you are. To whom we're going to be giving you that certificate, who's going to be attending the classes, who's going to be responsible for the payments. So we need to know lots of information. That will be your demographics. The same way that you're registered for the school, it is the same way that we are using some type of registration forms for the hospital to receive, just to receive for medical service. Can be a doctor's office or else. So that's how it works. So here it is, part of this patient registration screen form. See, when you're going to register your patients, if it is a new patient, they're going to ask you, because the only time that you register the patients and you pull out this form and be completed is when you have a new patient or when you have to update the patient registration form. Or we just don't say the patient registration form, we say the demographics. So if your doctor asks you, can you please, Alberto, print me out the demographics from the patient? This is exactly what you're supposed to be printing out. Now, that happens mostly with paper-based because we have the registration form in the front of the medical records in the chart. So we need that because they're going to fax it to someone or something like that. In electronic medical records, you don't have to do that. Why? Because the medical doctor have access to the system. They go, open it up, enter the system. But sometimes we have to do it, remember, because we have to be updating the patient's information. So every single time that the patient comes to our office, we're going to open this and we're going to ask the patient, because the patient is going to register for this particular, it's going to make an appointment. But we're going to ask them, hi, Mr. and Mrs. Smith, are you still living in the same address? Is your cell number still the same? Anything changed? Your insurance, have they changed? Do you have a secondary insurance? All these things are important when we have information. And we have to update the information every single time. If there is some changes, we have to make those changes. So that's basically what it is. So you're gonna go there and open the patient registration form. You're gonna see right there on your screen on your computer, your software application for electronic medical records or electronic health records. And you're gonna see right there on the upper ribbon that is gonna say, okay, patient registration, new patient, established patient, search, then if it is new patient, you start a registration form. And you just have to follow everything that is written right there. So that's basically what it is. If your office have a computer that is accessible to the patients and they can enter this information themselves, that will be a good idea, but not every single office has them. Some of them use tablets or a laptop, but if they don't, then you have to ask the questions and get all the information to the patient, from the patient. So that's basically what it is. If you're gonna make an appointment, you're gonna go there where it says appointments, schedules. If you're gonna get a referral, you're gonna find the forms right there for referrals. Everything is right there in your computer and your screen. You just need to get familiar and of course know how to understand what exactly is included in these systems. But it won't be difficult, I'm telling you. That's why every single time that your patient comes in, even though if you've been working there for a long time, you don't know all your patients. Nobody does. So if the patient have stopped coming to our office for a year, next time that the patient comes in, if you're new, you're not gonna know anyone. So every time a patient comes in, until you get familiar with them, you're gonna ask them, oh, I need to see a doctor. Sure, not a problem. May I have your name, please? Are you new? Don't tell them, are you an established patient? Because they're not gonna understand that. You're gonna ask, are you new? No, I've been here for a long time. Okay, let me get your name. And you got the information. Usually it's a good idea to get the patient's ID or the insurance. So you don't have to be asking twice. May I have your insurance, please? Then you have all the information from the patient, name, last name, remember, spelling, because sometimes that is problem. So you got the ID from the patient, enter the information of the patient. Always we start with the last name. And immediately you're gonna see there all the patients that are starts with that last name. As soon as we start typing, all the people that starts with those first letters, you're gonna see them. The more letters that you type, the more complete information that you type, the more specific you're gonna get to the person that you need. If it is a medical record, that will be unique, so that will be a lot easier. You just enter the medical record. Remember, you're gonna go to this little button where it says search, just like Google. Search for the patient, then you enter the patient information. I don't like to be picking something from the menu. Oh, Rodriguez. I really know the names from all the patients that are called Rodriguez, Smith, and all. No, I try to enter as much information so I can narrow down the name of my patient. Then compare, okay, date of birth. Oh, this is the one. And then I can do things right there, enter information. So that's how it works. We mentioned this before. We're going to have a master patient index, MPI. So what is exactly a master patient index? When we're going to have all the patients. This is like your contact list in your phone. That's exactly what it is. So we have all the patients that have previously registered, whether they are active, inactive, canceled, it doesn't matter. We have all those patients there. We just need to check the last date that they were seen by the doctor. Remember that even though if it is electronic, we can purge these patients, meaning we can move them to inactive files as well, or to closed files. So we don't have to be scrolling over all these patients to reach the patient that we need that is currently active. And what is the reason to have a master patient index? If a patient forgot or you don't recall and you start registering this patient again, as soon as you start entering the information, that name is going to pop out. And then you're going to see that this patient is already registered. So then we don't have to, but we're going to find those patients. See, I have my contact list on my phone, right? Even though if I block people, because I block people, of course, I block those unknown, I don't know who they are, those who give me a hard time, I block them. Well, we're not gonna do that in our electronic medical records, but we are going to purge, we're gonna remove, we're gonna place somewhere else those inactive, close. So that's basically what it is, just to make sure that we have only the active patients on the list. But all of them are going to appear, but we're going to know it says, oh, patient is closed, medical record is closed, this patient is inactive, so you know where they are, so you know what to do, a lot easier. So we know when was the last time that the patient was there seen and what was the reason the last time that they were there. So when the patient tell us, oh, I was here like a year ago, but by the way, they were like 5 years ago, you know that this patient is on medical records already closed and it will show there. So you have to register the patient as new. Regardless whether it's paper or electronic, if a patient has more than 3 years that has not been seen since last time, it's considered a closed file. So that's basically, but it will show there because we already purged it. We already labeled them as closed, inactive, and active. So that is the purpose of having a master patient index. Because remember, we don't register patients with alias. Oh, this name, oh, what is your nickname? No, we have to have the correct name, the real name. Unless the patient changes the whole thing, that's a different issue. Can deal with that, right? But then it will be a duplicate with a different name because the patient has already been there. But that's not something that we have to deal with. It is to make sure, because that's not our problem. It's not that we mess it up. It's the patient that is using a different name and with a different ID and so on and so forth. So that's basically what it is. So it doesn't create conflict. So right here, patient, the master patient index helps locate patient chart or paper-based system. Well, of course, we can have one of those in paper, but when we talk about electronic, it's gonna be a lot easier because we're gonna find these medical records just entering some, few information, few details about the patient. We're gonna find it right there. So this is the patient master, the master's patients index. Again, it's very simple. Just think about your contact people that you have on your, or contact numbers that you have in your cell. So you will walk to your contacts. That's basically what it is. And they're gonna appear dated when they created for the first time, when you add them as a new contact to you. So here, the whole information is going to be there too. When the person was first registered and, for how long this patient has been in the practice, whether, your medical records is active, inactive, or closed. Now we're going to move on to the laboratory information system. Remember, we're going to have within the software application, because we're talking about electronic, whether it's medical or electronic health records. Remember, we're going to have these interoperability systems. So we're going to have these interface systems that are going to be added to our system so we can receive the lab results. We can actually place an order through there, not just for the laboratory to get x-rays, but also to get blood, so body fluids, any imaging reports, medications. I can give my nurse, enter an order for the nurse. The nurse is going to pick it up because it's going to go directly to her site where the nurses receives the orders. And I said, oh, doctor ordered these medications for this particular patient at this particular time. So they're going to go prepare that. I don't need to give these written orders anymore. And it doesn't matter what the nurse is at. There is always a nurse station in each floor, in each department. So they just go there and check it out all the time. So that's basically how it works. So we're going to have everything to our fingertips. It's right in the system. I can order an x-ray, just take the patient over there, or the patient is already in the X-ray room. So just send the order, they take the order, they perform the test, then they send me the results, I evaluate the results, and then I can conclude a diagnosis for my patient. So that's basically everything is electronically interfaced. So it's very easy, very simple. Remember, back in the days when we used paper-based, we don't have that. To get the results, it took weeks. They send it via mail, in paper. Now, when we receive them, the doctor don't receive it immediately, or the doctor don't read it immediately. But if it is in the system, it's a lot easier because you can go there and look at it versus just, going over all those papers. It takes a little more time, and the time to get those results. So that's basically what it is. So you receive the information directly from the lab. So in order for these applications to be useful, they have to have certain components, certain pieces of software to interface. One of the most common is called the head level 7. You don't have to know that, the HL7 interface. But this is what connects. This is the part of the system that needs a laboratory to use, so certain images can be sent directly from the machine, from the X-ray machine or the MRI or the CAT scan or sonogram, can be converting these images and be sent it, as a digital image to the medical provider that have ordered those directly to the medical records for the patient. So that's basically what it is. We have lots of other systems like computerized provider order entry, CPOE. This is to send the orders for anything, any orders, not only laboratory, but for medications as well. So that it is compatible with the electronic health records. So it can be used. So that's basically what it is. It's very, very simple. So Laboratory Information Systems uses the acronym LIS, remember. Workflow of electronic lab orders. So I already told you this. So this is back again. Workflow is how these orders are going to be sent to the laboratory and how these results are going to be sent back to the sender. So to the computer of the medical doctor that placed that order. So that's basically what it is. You have to have these lab information systems once again. Without it, you wouldn't be able. It's like not having internet. You can have all these gadgets on your phone, but if you don't have internet, you're not gonna be able to use it. How are you gonna use Facebook if you don't have internet? How are you gonna use WhatsApp? You don't have internet. Twitter, Instagram, TikTok, all these social media. How are you gonna be able to Google something? It's the same with our laboratory application. You're not gonna be able to perform all these tasks without having these applications, these interface applications, I might say. So that's basically what it is. Now, yes, we can print this out, we can save it in a disk, we can save it in a drive, anything. But again, we have it directly from the source back to our system. As soon as this is done, this X-ray is done, the radiologist is gonna read it as soon as they are available and then send us this information to us. So we received the image, but we have not received yet the electronic, the reading, the official reading. Having the image of the X-rays, that's 50% right there of the work. Now I need the radiologist's interpretation of that. Remember, we as regular medical doctors or specialists that are not radiologists, we do interpret some of those things, but we are not the radiologists. So we have to base our findings or our treatments in our patient, our diagnosis with the reading, official reading that the radiologist collect from the image. So I can see the image, but if I don't have still the official reading from the medical provider, if it is a bacteriologist, a chemist, if it is a pathologist, if I send a biopsy or a blood cultures, I have to wait for their input. They have to read it first, interpret it, and then they send it to me. They're gonna tell me, hey, this patient has this. Now you manage how you're gonna treat the patient. I'm telling you what the patient has. What is it that is affecting the patient? Say, for instance, a radiologist is gonna tell you, oh, the patient has a fracture in this particular bone, this type of fracture. Now it is your job as an orthopedics to see how you're gonna treat that. It's not that the radiologist is gonna tell you everything. No, they tell you what is it, the basic. But we're gonna receive those images right there, and we have to wait for the reading. So that's what it is. The most important thing right here, back in the days, it was done again in paper. Somebody has to go get this information, wait until the doctor write it down, and then give it to us. So send it with a messenger. Now we get it right there in the computer. Both of the informations. The image we have it first, and then we receive the official reading. But we're gonna receive it within, depends of where we are. So if it is an emergency, we're gonna receive it within minutes. So we act right away. But it's fast, regardless of what it is, it's just fast. So we don't have to have that film that we're gonna put it under the light and then we're gonna try to figure out what it is, because it's gonna be very tedious to do that. So having this workflow of electronic lab orders plays a very important role for the patients, for the safety of the patients, because they can be treated faster. Here we have, this is talking about the digital pathology captures specimen images digitally. Now, once again, pathology has to do with disease. Path means disease. Logy means study of disease. So it's going to show within the report what disease the patient has. And you as a specialist, you're going to decide what is the best course of treatment for this patient. The pathologist is not going to tell you exactly what you should give to the patient, but they give you the problem. Now you have to solve it. They give you all the results. They give you the results. You just play with the results. That's our part. So here is when we're gonna use this other software application that is called Picture Archiving and Communication System. We use PACS for that. So every single system that we use, whether for imaging, whether for laboratories, whether for medications orders, we have different systems, applications that works with the electronic health records that allow us to capture all this information, and then we save it in our systems. And we can retrieve it any single time that we need it. You can go and review it. Anybody can go there and review them. So that's the beauty of having all this. Now we have radiology information systems. So again, we're going to use the same application system, which is called the PAC systems, because we are going to capture in same interface these radiology images. That's basically what it is. If we have a bunch of radiology orders, then we're going to see the status of each of these imaging reports that we send, the orders. This is like when you send something using any of these carriers outside, and they give you some information and some numbers that you can track down where the package is at this time. So we can track all these radiology reports that we send, these orders. And they give us time. Says, oh, it's in process. Oh, it's still waiting to be processed. It has been processed, it's waiting for the official reports. And they give you timing. It will be available 5 minutes, 10 minutes. If it's something went wrong, then they will let us know. The X-ray was not able to be taken. The patient collapsed. The patient was need to brought to do something else. Then we know the status, so we know what's going on. We're not going to be there sitting for the results. So now we're going to go see what else is going on. So it is interface with, the health information system, the electronic health records, with the billing department. So that's the purpose, because the billing department needs to see whether this X-ray was actually done, or was an X-ray, it was a CAT scan, it was an MRI. Why? Because each of these procedures have different costs. An X-ray is not the same price as an MRI or a CAT scan or a sonogram or a mammogram. So all these tests have different codes for billing because they're going to bill different values. But we're going to be able to see it in our health information system. Regardless of the department who use this information, they're just going to be able to enter, get the information, and then, the information stay in its original place. That's how it works. So I already mentioned all these images reports. It says examples of imaging reports. Digital X-rays, images, computerized radiography, digital radiography. So it's just the way that these images are portrayed, whether they are high density images or not. So that's basically what it is. We have CAT scans. That's the computerized axial tomography, which is a CAT scan. A magnetic resonance imaging, which is an MRI. Sonograms, anything else. So there are many, many, many reporting images in the laboratory for the X-rays. So that's basically what it is. So we're not going to worry about this. It's just the most important thing is that all these imaging reports that were ordered by the doctor and were processed, we receive the results, not just the results, not just the official reading when it says the patient, we encounter this in her lungs, in her bones, or stomach, or the intestines. No, but we can see the image itself. And it can be enlarged so we can see more details about the image. Some of the image can be in color or can be in black and white, but we're gonna have the image. So it's very interesting. Other things that we can do with the electronic health record, so anything that is digital, is we can do dictations, transcriptions. I mentioned this already. Remember who dictates? The medical doctor. The medical doctor do the dictation. That was back in the days. But when we see a patient, we can dictate something. Because we have paper base and we were very busy, so we tape it, we record it, and then we give it to a transcriptionist. That tape, we give it to a transcriptionist. That transcriptionist is gonna type it or write it down in the system. Still works because it works for the surgical department, where the medical doctor is busy with their hands, so they will not be able to type or write down anything. So they just talk. They have a headset, phone, and then it goes directly to a tape recorder. And then after they finish, somebody else is going to transcribe that. There were a time where they need lots of transcriptionists. Still, they do some transcriptionists. But being a transcriptionist is a little difficult. So again, just trying to understand all these medical jargon is very difficult. So you really have to be good at it. And after you transcribe all these voice recording into paper or typing it, somebody else has to review it again to make sure that it's accurate. If corrections needs to be done, well, we need to do the pertaining corrections. It's just that the doctor do not have the time to type all that information or to write all that information. So now it's type. So the medical doctor is going to go over. Not any medical doctor, has to be the medical doctor who dictate that information. Because as soon as I read it, I'm going to know if that's exactly what I wanted to, that I said, that it was recorded or not. It's not someone else. Remember, the only person that can correct information for the patient is the person who collected that information, not someone else, regardless whether it's a doctor or not. Because I'm not going to be correcting something that somebody else did. I don't know what they did. I have a conversation with you. You cannot ask your friend to tell you, okay, so what the doctor says. You are the one who had the conversation with them, not me. So the doctor is the one who needs to reproof these documents after being transcribed. So that's basically how it works. Now we have more advanced systems than when we are talking. It is typing, actually. It's not just voice recording what I'm saying at that moment, but it's typing it in Word. And it saves that in the system. I just go there and review it just to make sure. So I don't need a transcriptionist. I don't need another person to do the job. And then after they finish with that, I can go and review it. So things are moving, are evolving with technology. Every single time things are made of easier for us. And remember, this is to avoid errors because accuracy is the most important thing. Speech recognition software. I don't know if I mentioned it to you. I use this. Oh my goodness, that was a long time ago. So speech recognition is not something new. That came out by the time that electronic medical records came out. Because there was a need, remember. I use it, but I told you that it has lots of glitches. So it was difficult to use, particularly for us in people who have accents, even though if they were Americans and they were from the South and they have this accent, they were difficult for them to actually for these machines to capture these sounds. So we have to go there and review it. These machines needs to get accustomed. So we have to train them first. So we have to talk and see what is the results. Think about your phone right now when you use the microphone. That's speech recognition software. So when you're talking, if you don't pronounce correctly, or if you speak too fast, it's gonna type something else. So that's exactly with this software of speech recognition works. So it wasn't easy. They are easier now. They have kind of perfectionate how they work. Back in the days, they were very sensitive. So every single external sound was captured. Now the whole thing was a little messed up. Now things are a lot better. Now, if we have access to actually write it down, we can use our regular handwriting with an electronic pen on top of the screen and write things down, and it converts that. It types that for us. So we can use either or the speech recognition or just the transcribing of your handwriting to type in. I have used both. It's a lot easier to do the writing versus the speech recognition. I'm talking in my case, in some of the cases, and with my colleagues, because, well, we most of us were from overseas. But do we have the tools that if we train them, talking to the machine continuously, training to them to hear our voice and our accent, eventually they will get the information when we start talking. And you can try your phone, use the microphone, not to leave a voice message. I'm not talking about that. It's when you talk to your microphone instead of typing something, when you're searching something. I do that 99% of the time. I just talk to my phone. Tell me, what is this? Tell me where this is at. Can I have the number from this organization? I want to see something about how you build, how you do this. So I go there because I don't have time to be typing. It takes too long. But I do send messages, text messages, because that's a different issue. But now you have an idea how the speech recognition software works. So our phones has it right now. For the medical, it's the same. You're just talking and it's typing. in the system. Easy. So right here, errors may be corrected by users, software stores for future reference. Now, it has to be corrected by us, by the one that is using it, because you know what we're trying to say. And if it matches what you are trying to convey or deliver, no one else is going to know what you're trying to do or say, what information you want to convey. So that's basically what it is. So it is interesting. Pharmacy systems, I mentioned it already too. We are going to have the electronic health records connected to a computerized provider order entry, or CPOE. That's another software application because it's orders that you need to add. It goes for the pharmacy. I can use the same system to order medications for my patients in the hospital, in the emergency. The nurse picks them up and administer those medications. And there are less margin of error when we use electronic devices. Typing versus giving a written order or verbal order to the nurse or to any of the providers. So that's basically what it is. It's not just that we're going to place the order, but it's going to keep a record, a tracking record as well. And we're going to know whether this medication was dispensed by the pharmacy or not, whether the medication was filled by the pharmacy, whether the patient picked them up or not. See, when we gave the patients the paper slip to go to the pharmacy and get the medications, well, sometimes they misplaced the order, they lost that order, they never went to fill them out, they went back to the pharmacy 2-3 weeks later when this prescription pad was expired, because it was long ago that it was prescribed to the patient. Patient is not taking the medications on time. Now it's a lot easier. Our patient actually never fill out, get the medications. Let's put it that way. So for a lot of reasons, it was important to get this digital. Now we can actually track exactly what's going on with those medications. So I don't have to go back to the chart and try to look in the paper whether it's still there that know that I gave the patient this prescription, when was that, how many milligrams, and for how long was supposed to be taking these medications. Now I just can go and check medications, last medications, and all the medications from my patient shows up. And I have dates, times, and dosage, and amount of medication given per month, how many refills the patient still have, what type of medication was that, what schedule of medication. So that's a lot easier. So we have come a long way with electronic devices because everything is interface, see, connected to the system. Other parts of this pharmacy system includes decision support. So when you say decision support is what medication was given and was the medication, did the medication actually work? Whether the patient actually take the medication. So that is important because then we can control exactly what's being given to the patient, whether it works, whether it has secondary effects, how bad they work, whether we have to stop the medication, discontinue the medication, add another medication to it, and how we treat the patient if they have some side effects or anything else. We know whether your insurance company pays for it, because that is something that we didn't know before. That with paper, how do I know I have your insurance card? But it means nothing to me. But when I enter your information, enter the medication that I'm going to prescribe, you're going to have a notation that is going to tell me, hey, this medication is not covered by the insurance. But these are the options. So I can do that. Other than that, there will be a waste of time because the patient goes to the pharmacy to pick up the medications. The pharmacist is going to tell you, oh, you know what? You have to go back to the doctor because this medication is not covered by your insurance. Remember, usually your pharmacist cannot just be changing. You can't just change your medication. It has to be authorized by the medical doctor. Because remember, if I'm the medical doctor and I prescribe these medications in particular, that's what I have on file. If you change it, I might not know. But now with these systems, I do know if you change the medication. But it's the job of the pharmacist or whoever is dispensing these medications to let the medical doctor know before these medications are prescribed. Remember, pharmacists, they know lots about medications, but the pharmacists do not know other medications or conditions that the patient might be taking or having. So before I change the medications, I have to see whether this medication is compatible, it's not affecting other medications or the conditions that my patient have. The pharmacists don't have all that information. They just have history of medications, not conditions, because they do not need to know that. So that's basically what it is. So you're going to keep on track everything that is being given to the patient, whether the medication is brand medication or it is a generic medication. So all that's important. So if the patient says, oh, I'm having these side effects, they don't say I'm having side effects. I have an allergy to the medication that you gave me, because they think that everything that happens to them are allergies. Allergies are totally different than side effects. If you have diarrhea, if you have blowing, if you have nausea, those are side effects of the medication. Now, if you have a rash, shortness of breath, oh, that is an allergic reaction. That's a different issue. So if the patient says, oh, and call the office and says, oh, I'm feeling really bad, I was taking medication and I have this diarrhea or I have nausea or I have vomiting, or else, or an allergic reaction, we're going to know immediately which medications that the patient is being taking, because I have a list of all the medications in the system. I'm going to look at it and I'm going to see, well, by just looking at the medications, I'm not going to recall what side effects they have. I enter the medications that I prescribed lately to my patient, and I said, okay, which one is giving my patient this nausea or vomiting or abdominal pain or whatever else. So I look at it and says, oh, that's the last one that I gave. So let's stop the medication or let's give the patient something else for the symptoms, because the medication, as soon as the medication gets used to in the system, all these side effects are going to stop. An allergy do not stop. So anything that causes you an allergy has to be removed immediately. Side effect, that is a different issue. But remember, someone who has side effect to a medication If I develop diarrhea with a medication, I might stop taking the medication. What about the condition that the patient has? That's not going to stop. So I need to know. So the patient tells me, if I know that the patient stopped taking the medication, the patient called because he has these symptoms, now we can work with that. We can change those medications. But if it was in paper, who's going to know? If the patient calls, says, oh, I'm having diarrhea, something like that. Oh, if it is too bad, go to the emergency, otherwise come to the office when you want the appointment. But if I have all this information in the system, I just go and check it out and we can solve the problem a lot faster. So that's basically what it is. We have a lot of stuff that really, really helps. Emergency departments. So for the emergency department, this is crucial. Medications. Definitely. Because remember, it's an emergency. It's a life or death situation. So for hospitals, we have some of the same systems that we do have in medical doctor's office and something extra. So one of the problems that we have in emergency is because we don't have the patient's whole complete history. We don't have anything unless the patient has been there before. And we have electronic files on that patient. But if it's paper, no, because remember, every single time that the patient comes to the emergency or a patient has been admitted, what is it that we have to do? We create a new medical records. So every single time that we have a medical records, it's not going to tell the whole history about the patient. So that is a negative part. So we might have information about what we gave the patient when the patient came to the emergency, but we don't know other conditions that the patient is taking medications for or other conditions that the patient has. So if we don't have this information, it's going to be very, very difficult to act immediately and try to assist our patients faster because we don't have this health information management. Who are we going to ask? Oh, patient is unconscious. How are you going to ask the patient who's your doctor? Sometimes the family don't know. And it's an emergency. We don't have time to be trying to figure out what's going on with the patient outside of the emergency, the situation that the patient is having at that particular moment. We need to stabilize the patient. And then we figure it out if we need more information. Particularly, some of the things, like I mentioned before, allergies or medical history is something that we need, but we don't have in emergency. What if it is your first time? We know you were here once or twice, maybe 5, 10 years ago. Maybe a week ago, but we only have information about that particular visit, not your entire medical history. Nonetheless, your allergies. One of the things that we always have to ask your patient when they come to the office for the first time, or when you're going to do a procedure, when they're going to give the patients medications, is, do you have any medical allergies? We always inquire about, do you have allergies? That is not the right question to make. Allergies is general. There are many types of allergies. We have to be very specific. Do you have any medications allergies? I don't know. Well, non-known drug allergies. So we have to write down. You can write down non-known drug allergies to someone. Just ask, do you have allergies? I don't know. They might have food allergies, environmental allergies, So you have to be specific. Patients don't need to know. And sometimes patients say, yeah, I have allergies. And they tell you that they have allergy to a medication. And they tell you, oh, when they tell you what allergies they have, oh, I have allergies to aspirin. This is an example because aspirin is a very, very common allergy. So what are the signs? What are the symptoms that you develop when you have an allergy? Oh, I have abdominal pain, diarrhea, they gave me this. That's not an allergy. That is not an allergy. An allergy is that you develop a rash that you cannot breathe. That's an allergy. But if you develop diarrhea, nausea, vomiting, headache, that is not an allergy. That's a secondary effect. It's an adverse effect. So before we write down aspirin or any other medication that the patient tells you, we have to ask. Can you tell me what are the symptoms that you would develop when you say that you have an allergy? How do you know you have an allergy? What are the symptoms? And I'm telling you, because the patients do not know the difference. They just know that something didn't go right with this particular medication, or probably not even that medication. But we need to make sure that those questions are asked. If you don't ask, the medical doctor should ask. Remember, we don't know what allergies are. We don't know the difference between side effects and allergies as patients. So for that reason, it's important to check this out. Now, there is another problem that we have to consider in emergencies. Not only that we don't have your medical records, that you cannot tell us anything, you don't have a family member with you, so there's no sources for us to get information. Now, probably you never sign up for a medical office. You don't have medical records at all, anywhere. So that's another thing. Maybe you went to an urgent care. That's the only time that you've been in a medical. You don't even know what it was, but medical personnel is not going to have access to that. So it's very difficult. In emergency situations, one thing that I'm going to tell you what happened with emergency and questions for your exam. In emergency situations, everything changes. Everything is different. We're going to try our best to keep privacy confidentiality. It's not going to be met. Not 100%. Why? Because we have patients next to each other, people screaming, people talking. We are giving orders loud. Everybody hears everything about what the patient has. We try to keep it low, under control, but it's very difficult. People see the patients right there, semi-naked, here and there. It's an emergency. It's a madhouse. We're not going to be accused for violation of the patient's privacy and confidentiality. By the way, remember, in emergency situations, everything changed. So when you call the emergency to find out whether your loved one, your family member, your friend is there, have been admitted there because it's missing in action. So the person who answers the phone in an emergency, they're going to tell you, what is the name of the patient? Such and such. Do you know any other information? I have a name that matches that one. Okay, so what is your address? I'm going there. They can give you the information. You're not violating confidentiality because it's an emergency situation. In emergency situations, things change completely. Remember, in emergency situations, we don't need your consent. You cannot consent for us. Now, once again, Do not assume and put your personal experiences when you answer your questions. Oh, Professor Hoyer is not telling the truth, because when I went to the emergency, they asked me questions and they asked me what you have, and they asked me all this. They asked me about insurance. Yeah, you didn't have an emergency. An emergency is someone who is in a life or death situation. Whether we use the emergency for the other issues, that's a different thing. And that's when we get the questions wrong, because we base our experiences when we read the information, and then we answer the question based on that, not what I said, what is written in the documents. This is assuming that people actually understand what is an emergency. So whenever you have a question in your exam and it's talking about emergency situation, patient is unconscious, we don't need consent. The consent is implied. Consent is this person needs our assistance. We're not gonna wait until wake up, because he might not wake up. So again, do not assume that because you go to the emergency, because you forgot your prescription medications and it's a weekend, or you just have a little something, a little burn in your hand, and you end up with emergency. No, you can talk, you can do, and that's not life or death situation. It is not. We're talking about for a real emergency, because that was an emergency department built with that purpose, not for other situations the people is using it for. That's a different issue. So questions in emergency. First of all, patients in emergency, you're the medical assistant and you're working in the emergency department. A patient was brought in and blah, blah, blah. They ask you to give you, to draw blood for the patient or to do some procedure on the patient. What consent are we gonna use? Implied. Just the word emergency, the patient is unconscious, cannot talk, is implied. It's implied. Emergency situations do not need written statement because we assume the patient cannot respond. So we waive most of the things. So that is the key with emergency situations. And you will have these questions in your exam. And as soon as you read, that's what I've been telling you all the time, read the question. Is it outpatient? Oh, an outpatient. I have to ask patient's name, last name, date of birth. 2 points of identification. Oh, it's an inpatient. Oh no, I don't have to ask patient anything. Patient is hospitalized. I'm gonna check the wristband, the code bar right there, and then that's what I'm gonna do. That's what I'm gonna get the information from. Why? Because this person in emergency or it is admitted, we identify them differently. Because the patient might be talking, the patient might be conscious when it is admitted, but it is hospitalized. It might be under certain medications. It was admitted for a reason. We don't admit patients just because the patient asks us that they want to be hospitalized. The medical doctor who admits the patient or requests admission for the patient has to find a reason, serious reason, the patient needs to be treated in a hospital setting. For that reason, we're gonna give them an ID bracelet, and that's when we're gonna get the information from. So these are the type of things that you have to know it, because this is not a regular setting. That's what we have. Patient who is admitted, patient who is an emergency, patient who is an outpatient. If we don't understand those terms, then we're gonna have a problem understanding anything else, because we're gonna mix them up. It's not that the patient is here and the patient has to respond to it. No, there are some situations in which the patient cannot respond. Now, it's a different issue when you have the patient in front of you. Can the patient talk? The patient give you information? Well, we asked information, but if the patient cannot, if it is an exam, they're not gonna tell you. The patient is in an emergency, the patient can talk, and tell you, no, they're not gonna say that. He says that the patient is an emergency, probably is unconscious, but just the fact that it's an emergency, you know already what should be the next step to identify the patient or to get the consent from this patient. Any questions? Perioperative software. Now, these are software applications that we have from the moment that we order a surgical procedure to our patients, because it's gonna record preparation for the surgical procedure, all the instructions the patient has to follow according to what procedure the patient has to get. Then it's going to record everything that happens during the procedure, and then everything that happens after the procedure, post-surgical recovery, which is totally different. See, this is a software application for someone who goes through these transition times, episodes, versus someone who just go to the clinic, do whatever they have to do, and they go home. Because remember, these patients, we are going to give them some instructions how to prepare themselves prior to the procedure. We're talking about elective procedures. See, an emergency procedure is something that you were brought to the emergency by the ambulance and you have a life or death situation. We have to act immediately with the procedure. We're not gonna go through pre-operative, operative, and post-operative. No. But someone who has an elective is someone who we counsel in the office. We tell them what is this procedure required, what this surgical procedure is required. Just sign a consent form. And then we're going to give you all the instructions how to prepare prior to the exam. Follow certain diets, stop certain medications, stop these lifestyle changes like smoking and drinking prior to the surgical procedure. Then you come to the procedure, we're gonna prepare you for the procedure. All the things that has to be done. Then we're gonna record everything that happens during the procedure. And then after the procedure, what is it that you have to do to recover yourself? So that's basically how it works. Now, that works for inpatients and outpatients because you can have an outpatient's procedure. You have a colonoscopy, you don't have to be admitted. But you need someone else who bring you home because we're going to give you some type of local anesthesia. You might be at risk. So certain procedures that you need to take care after the surgical procedure. So that's basically what it is. We're going to give you medications. We're going to give you certain supplies. If you're going to do wound changing, clean it up, we're going to give you all the tools that you need. And probably you have to go back and forth to the clinic to your home or having someone to go to your home. We made all those arrangements for you. And everything is going to be recorded right here in this software application. That's how it works. So the whole information is going to be there. Who did the surgical procedure, for how long the surgical procedure was, who was the assistant, who was the anesthesiologist, what anesthesia was given to the patient, what medication was given to the patient, how the patient responded to the surgical procedure, for how long the patient after the surgical procedure, we kept them in the recovery room, or was hospitalized, so the patient died during the procedure, or the patient got complications. So all that information is going to be recorded there. And it's going to be our fingertips. Very, very simple. Any questions? Okay, so I know you're going to be very upset, because I know you're going to be very upset.